In this lecture, we're going to look at brain tumors, talk about the most common brain tumors in adults and in children, and talk a little bit about some of the red flags that you might want to consider when patients present with specific signs and symptoms that might indicate a brain tumor and also a cerebral vascular accident. And then we'll talk about other things like acoustic neuromas and so forth. So brain tumors can be either primary or secondary. And the most common tumors are secondary. So secondary means that the tumor is coming from metastasis from another tumor in the body. So the most common sites would be things like lungs, breast, kidney, the GI tract, melanomas. These will form outside the brain and then they metastasize through the blood and then they set up tumors in the brain. Usually these occur at the gray-white matter junctions, and there can be multiple discrete tumors. These are rapidly growing, they're very invasive, there's a lot of necrosis of underlying nerve tissue, and there's new tortured blood vessels that grow into these tumors. So those are secondary brain tumors. So we're going to focus on primary brain tumors. They're not as common, they're only about 30% of all intracranial neoplasms. Remember, neoplasm just means new growth, and that would be a tumor, and that could be either a benign tumor or a malignant tumor. So malignant, again, is where the tumor can spread, whereas benign is just going to grow locally. That can still have negative effects. It can compress local structures, cause damage that way, but it won't spread to distal sites in the body. In terms of primary brain tumors, 40% are benign, and they rarely spread beyond the CNS. 60% are malignant. So the most common primary CNS tumors in adults would be glioblastoma multiforme and a meningioma. And the most common primary CNS tumors in children would be medulloblastomas and astrocytomas, and we'll look at what these are in just a moment. Most adults' primary brain tumors are supratentorial. Remember, the tentorium is the membrane that separates the cerebrum from the cerebellum. So supratentorial means above that, so it's in the cerebrum usually. Versus the majority of childhood primary brain tumors are infratentorial, below that, usually affecting the brainstem or the cerebellum and so forth. So that's one differentiating feature here. Okay, so that's the primary versus secondary brain tumors. Our history and PE, usually for brain tumors, are going to depend really on several factors. Symptoms will really depend on the tumor type and location, their local growth, and what's called mass effect, which is compression of surrounding structures, and then cerebral edema or increased intracranial pressure could also be manifestations of a tumor. Usually hemispheric tumors in the hemispheres produce visual field abnormalities, maybe neuropsychiatric symptoms like personality changes and so forth, because that's all affecting the higher brain centers. Versus paracellular lesions, these are around the sella turcica where the pituitary sits inside of. So we'll talk about pituitary tumors separately. We've already said a little bit about that previously. But these would typically have changes in vision, or double vision would be characteristic of those. And then posterior fossa lesions, they tend to present with gait, ataxia, and cranial nerve deficits or increased intracranial pressure. So headaches, only about 31% of patients with headache at the time of diagnosis have brain tumors. So that's not always needed to, that's not a characteristic sign necessarily of a brain tumor, but unexplained headaches that kind of come up out of the blue that don't have the characteristic patterns of migraines or tension headaches, which we'll talk about, brain tumor might be something on the list. The thing about tumors is they're going to be constant, steady, and just progressively getting worse and worse and worse. So again, here only about 8% have headaches as the sole presenting feature. There can be seizures that are stimulated by tumors, and this is going to be maybe the most common thing. So I've had a couple of patients actually, they just started developing seizures. And one of our big red flags there is brain tumor. And so we need to send for imaging and appropriate workup for that. Again, depending on where the tumor grows, there could be increased intracranial pressure. And that could include symptoms like headache, nausea and vomiting, double vision. And so that would be one possibility. But usually these tumors are caught with neuroimaging MRI or CT before they get to the place where they're going to compress the ventricles and inhibit the intracranial pressure. So that's that. And then metastases that tend to present with intracranial hemorrhage would include renal cell carcinomas, thyroid papillary cancer, what's called choriocarcinoma, and melanoma. So these would be these would be secondary brain tumors that would be set up from these particular sites. So the classic approach to working this up would be to do neuroimaging. And that would be either contrast CT, but usually MRI, either with or without the gadolinium. And that's going to really help us localize potential lesions and look at their extent. The gadolinium-enhanced MRIs is generally better for visualizing soft tissue tumors and looking at the vascularity around that tumor, whereas CT is better for evaluating skull-based lesions, and then again for the emergencies that we talked about, like in the CVAs. So generally MRI with contrast is going to be our typical thing for working at brain tumors. There can be biopsy as well, and that would be through the skull, basically, and that would be a neurosurgical technique. And the biopsy would help us stage the tumor and look for different genetic markers and so forth that can help guide therapy. So the treatment for this, just in general, would be usually symptom management, and that would be things like anti-seizure medications. So if you have patients that have brain tumors, like the glioblastomas, you might find that they've been given anti-seizure medications and then potentially corticosteroids to decrease their intracranial pressure. And then really for many of these, there's no definitive treatment. The tumors cannot usually be completely surgically removed. Chemo is not very effective for many of these. So the typical approach is what we call palliation. And that's really going to depend on the tumor type and location. But usually that involves some degree of surgical resection or debulking. Radiation therapy, chemo, again, this is meant to kind of shrink the tumor. But now we're seeing more and more immunotherapies arise, and that could be a game changer for brain tumor treatments. Immunotherapies really are ways of triggering the immune system to attack the tumor directly. And that's just in its infancy, but I think we're going to see a lot more developments in that field in the near future. So that's just kind of a general idea about the treatments for brain tumors, and we'll look at the different tumors here next. Let's look at some of the common primary brain tumors in adults. And the first one is going to be a meningioma, or meningeal tumor. These are the most common CNS tumors, and the good thing about them is that they are they have very good prognosis. So the most common CNS tumor, they're actually found growing in the meninges, so they are outside the actual brain tissue itself. And the biggest problem with these is as they grow, they put pressure on the brain, because again, as they grow, they can't expand outwardly. So if you look at the picture over here, here we have an MRI coronal section with the meningioma, and you see it's on the surface, near the surface of the brain. As it grows, it can't press this way, it's got to actually expand this way, so it's going to expand into brain tissue. So the symptoms we get from meningiomas tend to do with increased intracranial pressure, or what's called the mass effect as it expands. And that might present with focal seizures, spastic weakness, again depending on where it's located on the surface of the brain and what areas underneath it's compressing, and then increased intracranial pressure. So this would be meningioma. A lot of them have a good prognosis. Many of them are found incidentally on MRI. Patients have no symptoms, and they don't tend to enlarge very quickly, so they just kind of do what's called watch and wait. Let's see what happens with this. The incidence increases with age. So the treatment might just be observation. There can be, because it's close to the surface of the brain, these are easier to remove surgically, and then targeted radiation therapy might be used. So that's the first type of primary brain neoplasm in adults. So the next most common type of adult CNS tumor is what's called glioblastoma multiforme, or GBM. It's also known as a grade 4 astrocytoma, and from the name you can guess that it arises from astrocytes in the brain itself. Here we have another coronal section here, MRI, and very different appearance than the meningioma. This is affecting the brain parenchyma itself. Notice it's pressing across the longitudinal fissure. It's pressing into the other hemisphere here. And they can actually cross the corpus callosum, so they can go from hemisphere to hemisphere. They can grow into the meninges and the ventricles, and they progress very rapidly, so they have a very poor prognosis. And typically with GBM, the 1-year median survival rate is less than a year. So usually these begin in later life, and they're more common in males. And they present typically with the classic symptoms and signs of increased intracranial pressure, so headache, nausea, personality changes, again, focal deficits and seizures. Pretty common theme here with the brain tumors. This treatment is, again, symptomatic or palliative. Symptomatic would be with anticonvulsants, corticosteroids. Palliative would be surgical removal, radiation, chemo, and immunotherapies. So that's a grade 4. Grade 4, usually tumors are staged, grade 1 through 4, depending on the staging system. Grade 4 is the most severe. Now, there are grade 1 through 3 astrocytomas, and these also arise in the brain parenchyma. They're relatively uncommon, so they're not as common as the grade 4s in adults. They're more common in children and young adults. And this has a more protracted course than the grade 4, the GBM, and better prognosis. So the presentation is going to vary, but it's going to be, again, similar depending on the location of the tumor, with maybe seizures and focal deficits and headache. And the treatment here would be using, again, anticonvulsants and steroids to reduce the intracranial pressure, and then palliative procedures with surgery or radiation. So those are astrocytomas, and again, a grade 4 astrocytoma is a glioblastoma, more common in adults, very poor prognosis with the grade 4. Another type of glioma would be oligodendroglioma, and these grow from oligodendrocytes. Remember, they provide the myelin around axons. These are not as common as the GBMs, the grade 4 astrocytomas. They're about 9.5% of all primary brain tumors. The average age of diagnosis is around 35, and they occur most commonly in the frontal lobes. And there's often calcification seen, calcium deposits inside these tumors. They're slower growing, and the survival really varies by the grade. So grade 2, the median survival is 11.6 years. Grade 3 is 3.5 years. Now, when we talk about the median survival, again, this is just based on statistics and looking at all the people with this. There are, of course, outliers. And so it's always important to not focus just on these numbers in this way. But it can give you a little bit of a sense of how aggressive a particular type of tumor is versus another type. And that can help guide therapy and so forth. Again, the presentation is going to vary. Your classic presentation of seizures, increased intracranial pressure, and the visual loss, cognitive decline. Treatment here, too, could be observation for the lower grades, symptomatic therapy, anticonvulsants, corticosteroids, and then palliative therapy if indicated and possible with these tumors. So that's an oligodendroglioma. And then another tumor, which is it's a benign tumor of myelin-forming cells that forms around cranial nerve number 8, your acoustic nerve. And this is called a vestibular schwannoma. It used to be called an acoustic neuroma, but it's really the Schwann cells which overgrow, schwannoma, and it's affecting the vestibular acoustic nerve. It actually arises, so the cranial nerve number 8 has 2 divisions. So to be really specific, it has a cochlear division, which is going to the cochlea for hearing, and there's also a vestibular division that goes to your vestibular apparatus, your semicircular canals, for balance. And the tumor arises in that vestibular division, which is why we call it a vestibular schwannoma. It's rare. There's less than 20,000 cases in the U.S. per year, usually very slow growing, but it can grow rapidly, and it can compress the 8th cranial nerve, and that can result in unilateral hearing loss, tinnitus, and vertigo. So that's the classic pairing, those 3 symptoms with the vestibular schwannoma. And the diagnosis here would be MRI with gadolinium contrast. So the presentation is going to be unilateral hearing loss in over 90% of patients, tinnitus, and vertigo. Those would be the 3 classic. And so balance, ear pressure, facial weakness, headache. Larger tumors can even compress the brainstem. So there are several microsurgical techniques that can be used to either debulk or remove the tumor. Radiation can be used in some cases, but many cases just require observation and then symptom management for the dizziness and so forth. So here you can see the ear apparatus. So we have the outer ear here. Here's the eardrum. Here is the middle ear with the 3 middle ear bones. Here is the inner ear with the cochlea, which is where the hearing occurs. And then here is the vestibular apparatus. And so the 8th cranial nerve innervates both the cochlea and the vestibular apparatus, and that's going to the brainstem. And here we see the acoustic aroma growing in that canal. So as it compresses, it can compress, the brain tissue in this way. It can compress the brain stem, but generally it's affecting the function of the vestibular nerve. And so that's going to give us our classic symptoms of the hearing loss, tinnitus, and vertigo. So the vertigo is probably most distressing for people. They just feel vertigos where you feel the room spinning around you all the time. You might get nauseous and everything from that. So that's where medication therapy can be helpful, but really the treatment needs to be ultimately debulking of the tumor. So that's a vestibular schwannoma. Next, let's look at a couple of primary neoplasms that can occur in children. So medulloblastoma is actually the most common primary brain tumor in children. It arises from the cerebellar stem cells, interestingly, and it arises mostly from the 4th ventricle in the cerebellum. So these are infratentorial, they're under the tentorium. And the main thing here is that they cause dramatically increased intracranial pressure. Because remember, the 4th ventricle there, if it gets compressed, that's what's leading out of the brain. It's going to go down to the spinal cord. If that's compressed, the cerebral spinal fluid increases in pressure. These are highly malignant, invasive, they're very rapidly growing, and they spread all throughout the cerebral spinal fluid. And then they metastasize to different parts of the brain and spinal cord. That said, the 5-year survival rate's about 60%. So the presentation is going to be all the classic signs of what we call obstructive hydrocephalus. Hydrocephalus is just a name for increased intracranial pressure. So severe headaches, nausea, vomiting, diplopia, ataxia, papilledema would all be signs and symptoms of this. Papilledema is actual swelling that can be seen in the retina, so this is why we use the ophthalmoscope to examine the retina, and that's a sign of increased intracranial pressure. Treatment would be to really kind of symptomatically just decrease the intracranial pressure with corticosteroids, with shunts, again, that might shunt the cerebral spinal fluid into the peritoneum. That's called a ventricular peritoneal shunt. And then palliative therapy with surgery, radiation, and potentially chemotherapy. So that's a very aggressive brain tumor, primary neoplasm in children, a medulloblastoma. And a ependymoma arises from the ependymal cells of a ventricle, usually in the 4th ventricle again. So it's infratentorial, or maybe even the spinal cord. Again, very poor prognosis, and in children this can occur within the skull here. In adults, if an ependymoma occurs, it typically is intraspinal, and this can cause obstructive hydrocephalus again. So classic signs of increased intracranial pressure, headache, nausea, double vision, papilledema with vision loss, and then ataxia. And again, same thing, treatment here is mostly palliative. Final tumor to talk about here in children is a cranial pharyngioma. This is rare, benign, slow growing. It's derived from embryonic pituitary tissue, what's called the Rathke's pouch. So the pituitary actually forms from 2 different types of cells, one coming from the oral mucosa, called Rathke's pouch, and the other coming from the brain. And so when they come together, they form the pituitary. Specifically, the anterior pituitary forms from the Rathke's pouch material. These grow along the stalk of the pituitary, the infundibulum, and can affect adults, but it's most common in children. And the peak incidence is around either 5 to 14, or there's another uptake between 50 and 74 years of age. Very rarely these are malignant, usually they're benign, but they can still cause a mass effect, or what's called stalk effect. and that is from the enlarging of the tumor, can compress the infundibulum. As a result of that, that would block all those hypothalamic hormones from going into the anterior pituitary. And remember, that would essentially then shut off your growth hormone, ACTH, TSH. It would also tend to compress the nerves that are going to secrete ADH in the posterior pituitary. So we'd have all symptoms of that. So remember, antidiuretic hormone is preventing you from urinating. So if you had decreased ADH, we have essentially diabetes insipidus with polyuria and polydipsia, frequent thirst. Decreased growth hormone, we might see stunted growth and fatigue. And then ACTH, we're going to see adrenal insufficiency, and then TSH, deficiency of hypothyroidism. Now, stalk effect causes something interesting. So remember that the dopamine is normally inhibitory to the secretion of prolactin. So by blocking the dopamine coming down from the hypothalamus, we actually get increased prolactin. And so that's going to happen in more larger tumors. So the treatment for craniopharyngioma is, number one, replacement of the right hormones. So replacement basically of all these hormones like growth hormone, cortisol maybe, and thyroid. And then surgery. So there are different approaches. We talked about these with the pituitary adenomas. So remember, pituitary adenoma is a tumor in the pituitary gland. I already reviewed those, and if you've forgotten about that, you might want to go review that section. But that would be another type of brain tumor. But this, the treatment for this would be either to go through the nose, and I'll enlarge it here. This is called the transsphenoidal approach. So here we see the craniopharyngioma. Here's the pituitary gland. And so we can actually go in, drill through the bone here, expose the pituitary, and then start to debride, debulk the tumor to try to remove it. That's called the transsphenoidal approach. The other approach, unfortunately, is to essentially remove the part of the frontal bone, and that exposes the underlying brain tissue, and then the brain could be, the frontal lobe can be lifted up, and that exposes the tumor. And so then it can be debulked for very large tumors, and that's called the subfrontal approach. And then there's targeted radiation therapy. So that would be a craniopharyngioma, benign, slow-growing, coming from embryonic tissue, Rathke's pouch tissue, growing along the pituitary stalk, and basically affecting the pituitary and all the local structures. Okay, so those are some of the most common primary brain tumors in children. Now, just the final word here on red flags. So again, red flags mean urgent referral. They mean level 4 therapy. And so these are things to keep an eye out for. So a rapid decline in mental or social functioning is going to, rapid progressive, it can mean many different things. It could be, if it's really slow, it could just mean it's dementia. But if it's more rapid, that might be a sign of recurrent TIAs, potentially an extradural hemorrhage, like in the elderly person who maybe takes a fall or something. But it could also be a sign of a brain tumor. Now, of course, I'm not talking about stroke here, but we're just looking at just sort of progressive, rapid decline in mental and social functioning. This could be over usually days, weeks, and so forth. So again, a stroke would be within minutes. So this is more longer term. Now, one thing that's always confusing with dementia, and we'll talk about dementia in the mental health section, but dementia can be sometimes mistaken for depression in the elderly. So that's something we always want to keep an eye out for. I'll discuss that later. A temporary loss of neurological function, usually within 2 hours, so loss of consciousness, loss of vision, unsteadiness, confusion, and so forth. So it could be, something as simple as a migraine, or pre-syncope or syncope, where a person has low blood pressure and they pass out. But this could also be a TIA or stroke. So if you are concerned about stroke, go ahead and make that urgent referral. Persisting loss of neurological function, such as loss of consciousness, vision, unsteadiness, confusion, loss of memory, loss of sensation, or limb and muscle function. Again, stroke, but if it's more persistent, long-term, slow-growing, this might be a tumor. It can also be a CNS or spinal cord disorder like MS. If, again, the symptoms happen in the past few hours, we're thinking stroke, make that emergent referral. A progressive headache with vomiting, usually time scale of weeks to months. Headaches worse in the morning and worse bending over. Very severe headaches with kind of just copious vomiting. You just keep vomiting for some reason. Blurred vision, double vision. This could be a slow increase in intracranial pressure. And that could be many causes. Again, if the cerebrospinal fluid drainage is blocked, we call that hydrocephalus. But that could be a brain tumor again. That could be a brain abscess, which is an infection. We'll talk about those later. Or an extradural hemorrhage, again, a bleed that's pushing on that. And you see the problem with the hemorrhage again is the uncal herniation. So here's the uncus, and the uncus is pushed down into the brainstem. So that would be one possibility there. And then a sudden worsening of headache or vomiting, time scale here, hours to days, with severe headache, vomiting, double vision, pinpoint pupils, irregular breathing patterns. This is a rapid rise of intracranial pressure, and that's usually due to an intracranial hemorrhage. And so that's, again, going to be an urgent referral. So those are just some of the red flags to keep your eyes open for, and that might be just telling to say it's time to call emergency services and go that route. So that summarizes it for brain tumors. Just know a bit about the most common brain tumors, primary brain tumors in adults and then in children, and then what their most common manifestations will be, and know a little bit about their prognosis. So that summarizes it for the tumors.